Thank you very much for the kind invitation. I'm going to talk about venous leg ulcers and update on current evidence. So we all know that the underlying pathology of venous leg ulcers is ambulatory venous hypertension, which is caused by obstruction or reflux or a combination of both. They cause increased intranumeral pressure, which causes protein extravasation in the capillaries and the formation of fibrin cuff, which in turn impede the diffusion of oxygen and growth factors and activates the inflammatory response, resulting into the formation of venous leg ulcer. And we know that there are some risk factors which increase the probability of developing venous leg ulcers, such as obesity, age, male gender, prolonged standing, and maybe trauma in some patients. But does this answer all the questions? Well, it doesn't, because why some patients with obstruction and reflux never develop ulcers? We have all seen patients with varicose veins in our clinics who develop ulcers early in their life, and we have seen patients who are in their 70s maybe or 80s, and all their lives had varicose veins and they never developed an ulcer. Why some patients develop venous leg ulcers without any underlying venous pathology? We have all seen patients with typical ulcers in the gaiter area surrounded by pigmentation, lipodermatosclerosis, and we refer them to have duplex, and duplex come back as normal, and they have a second duplex and third duplex, and it's all normal. So there must be other things. The etiology of venous leg ulcers is complex. The inflammatory response is complex and varies from person to person, from mild to severe. In addition, as mentioned before by Professor Ayman Fakhri, there is a genetic influence. So there is a genetic factor which makes some person more predisposed to develop ulcers and recurrent ulcers than others, although they have exactly the same pathology. And interestingly, there are microvenous valves in the very tiny venules. So in this particular example, there is retrograde filling of resin into the microveins. That's a specimen taken from a person who had a competent great saphenous vein. And this can explain why some patients, have a mild form of venous pathology and yet their ulcers are so difficult to heal and they recur. Now going to treatment. The key in the treatment of every venous leg ulcer is compression therapy. We all know it has received a grade of recommendation 1 and the level of evidence A in the American Venous Forum and the Society of Vascular Surgery clinical practice recommendation, and we all know that level of evidence A is based on multiple randomized controlled studies which has shown an advantage towards the use of compression. And I would like to share with you this meta-review. Meta-review is a review of reviews. So this is a review of 12 systematic reviews that was published during the 15 years from 97 to 21. What did it show? It showed that there is a statistically significant difference in healing rates when compression is used versus no compression. And also it showed that there is no statistically significant difference in healing rates of venous leg ulcers when comparing elastic versus inelastic compression, when comparing 4-layer versus less than 4-layer bandage, when comparing different types of 4-layer bandage, and when comparing compression bandages versus compression stockings. So the key message is compression is essential, regardless which type of compression. And I would like to let some light on this relative new technology, the adjustable wraps or the Velcro wraps. That's a review of 14 case reports and one randomized study. It's a small number of patients, 192 patients. It showed improved time to healing, reduced cost, reduced number and duration of medical appointment, and improved quality of life. So although the evidence is early and is still based on a small number of patients, it has a lot of potential. And also I would like to shed some light on this study which tried to answer the question, do compression stockings reduce the incidence or the severity of post-thrombotic syndrome when used immediately after acute DVT. So these are Chinese authors, and they used compression stockings immediately after acute DVT. And they showed that the use of elastic compression stocking will reduce the severity of post-thrombotic syndrome, and that this reduction becomes more obvious as time goes by. I'll talk a little bit about the superficial venous reflux and its relation to the venous leg ulcers. This is the most important report so far. That's the EVRA trial. It's a large trial which was performed in the United Kingdom in about 450 patients, which were randomized into superficial venous system ablation, that is ablation using thermal ablation, non-thermal ablation, or stripping, versus delayed superficial venous system ablation. And it showed that early ablation would reduce the time to ulcer healing, more patients had healed ulcers, and greater ulcer-free time. So the message out of this study, which is a very important study, that venous leg ulcer in the presence of superficial venous reflux, the sooner we abolish the superficial venous reflux, the better regarding ulcer healing. But did this study answer all the questions? No, there is a question that's still unanswered. What's the best treatment or the best approach to a patient who has venous leg ulcer, superficial venous reflux, and post-thrombotic changes in the deep venous system? I'll talk a little bit about the deep venous reflux in relation to venous leg ulcers. Very early on, about 20 years ago, Raju and his colleague showed that there is a relation between chronic iliac vein obstruction and venous leg ulcers. So patients with venous leg ulcers have a higher probability of suffering from chronic occlusion, and if this chronic occlusion is relieved, the ulcer healing improves. Recently, last month, they published a very interesting study that is what happens to the infrainguinal reflux after stenting of the proximal iliac vein occlusion. So they compared two groups of patients. Patients who had infrainguinal reflux versus patients who did not have infrainguinal reflux. Both groups had iliac vein stenting, and they showed that there is no difference between the two groups. It means that a patient with venous leg ulcer and proximal obstruction, if we relieve the proximal obstruction, most probably the infrainguinal reflux will not make a difference to the ulcer healing. Finally, a word about incompetent perforators. Well, it has been already said that incompetent perforators were first described by Linton about 100 years ago, and then described by Cockett in 1958. Linton described his Linton procedure. Some of us may have performed this procedure, which consists of opening up the posterior compartment of the leg and identifying and ligating all the procedures. This was replaced in the 80s by the SEPS operation, subfacial endoscopic perforator surgery. This was very widely performed in the 80s and the 90s and the early 2000s until the SCAR trial was published. The SCAR trial compared compression alone versus compression and SEPS procedure. And they showed that the SEPS procedure did not make any difference. And from this time, the SEPS procedure was not reimbursed in the West, and it died off completely. As we just listened from Professor Ayman Fakhri, recently percutaneous ablation of perforator has been introduced, but to my knowledge, there is no strong data to support the use of percutaneous ablation for the treatment of venous leg ulcers. There is only early data. Are pathological incompetent perforators regarding their role in the venous leg ulcer a reality or a myth? There has been some anatomical studies which showed that some incompetent perforators some venous perforators have no valves, or only have remnants of valves. Also, there has been a theory that venous perforators have bidirectional flow during contraction and relaxation. And this bidirectional flow is important to equalize the pressure between the superficial system and the deep system. So they actually play a physiological role. And using advanced software, advanced sonographic software, only 28% of what is considered pathological perforator with our current machines have been found to have a net outward flow. So the question mark remains. These are the network of underlying refluxing vein that we find under the majority of venous leg ulcers. And we use this technique of ultrasound-guided foam sclerotherapy of this refluxing venous plexus underlying the ulcer. And we have reviewed our series retrospectively, so that's 159 patients who had venous leg ulcers, and this technique of ultrasound-guided foam sclerotherapy gave excellent results. This technique has been first reported in 2005, a good 15 years ago, and there's been many reports since, but there has not been any single randomized controlled trial. So as I mentioned earlier, we're currently conducting a randomized controlled trial comparing the use of ultrasound-guided foam versus no foam in two groups of patients, and that's a multi-central trial being performed in Egypt, and we hope to be completed by the end of this year. This is our protocol for treatment of open leg ulcers. They all have a duplex, and if there is venous pathology and no contraindication, all have compression therapy, and of course the necessary wound care. If they have superficial venous reflux, they'll have great saphenous vein ablation, ultrasound-guided foam for the extra-axial varicose veins, and ultrasound-guided foam for the ulcer veins. If they have deep venous obstruction, they will have iliac vein stent. In this case, they will not have great saphenous vein ablation, even if it's refluxing. They will only have ultrasound-guided foam for the ulcer veins. So my key message is, for the treatment of venous leg ulcer, those elements have to be considered. Compression is a key element, abolition of superficial venous reflux by any method, stenting of iliac occlusion if possible, and ultrasound-guided foam sclerotherapy for ulcer veins, which we hope we find a good basis for the use of this, and finally, wound care. Thank you for your attention.
Thank you, Dr. Rashad.